Hello and welcome to the Fit to Transform podcast, where you learn how to train and diet effectively and, most importantly, how to maintain those results for life, once and for all. I'm Nikias Tomasiello, a transgender training and nutrition coach working online with anyone who's ready for a true lifestyle transformation, anywhere they may be in the world. As a friendly reminder, any and all information provided is for educational purposes only. You should consult with your doctor before implementing any changes to your diet and exercise program. With that disclaimer out of the way, thank you for being here. Now grab yourself a cup of tea or pre-workouts and enjoy. Yo, dear listeners, welcome back to the podcast. You're about to tune into an interview with Cory Hageman, with whom I discussed PEDs, or performance-enhancing drugs, also known as steroids. This was a very honest and open conversation about their usage, their side effects, their benefits. And I believe that it's going to be extremely informative, especially if all you know about steroids is what most people know, which is that they are considered cheating in the Olympic Games. Now, as part of this introductory note, I wanted to let you know that this interview came up to almost 90 minutes, so I split it into two parts to make it a little bit more palatable, and you're going to get part 2 next week, as always, on a Friday. Without further ado, let's get into the conversation. Yo, dear listeners, welcome back to the podcast. Today, I'm sitting together with IFBB Bikini Pro Cory Hageman. Cory, actually, I meant to ask you, is that the right way to say your last name?
Yeah, no, that's perfect. Very, very few people get it right on the first try without double checking beforehand. So no, thank you. It's spot on.
It's the second time now that I realized belatedly that I wanted to double check a last name. And the first time it was a bit more awkward. This time I got it right, so I'm pleased with myself.
Beautiful, beautiful. How long have you been podcasting for, if you don't mind me asking?
I started the podcast in July 2022.
Wow. Okay. So you're a seasoned vet. I mean, being in the host chair, that was a pretty different position for me to be in. At that point, only been coming on podcast, but it's nice to be able to have your own platform that you can ask all of those like hard pressing questions that you have around various topics.
Absolutely. I love interviewing the most because I also do solo episodes just like you do. But when I get to sit in the chair and just ask the questions and sit back and learn, that's my favorite part.
No, no, I feel you.
In any case, dear listeners, I brought Cory on today to have an honest conversation about the use of performance enhancing drugs, or PEDs. The kind of compounds that most people typically call steroids, although they're not limited to only those. But Cory, before we start, I would like to break the ice with a question I ask all of my new guests so that my listeners can get to know them a little bit better. And that question is, who are you? What do you do? And why are you so awesome at it?
I love that. No, it really sets the tone. So for listeners who aren't familiar with my content, I'm an IFBB Bikini Pro. So within the bodybuilding space, I compete in the bikini division. Um, I've been doing this for about 10 years. And I would say like the thing that I've gained more notoriety around doing is putting out educational information specifically around pharmacology and sports performance for largely female athletes, but also male athletes as well. And within those scopes, the potential risk profiles that are associated with the use of various compounds within our sport. And within that, I mean, like I know that there are very educated individuals who speak on these compounds as well, but I wouldn't necessarily say I am awesome at it, but I do think I really try to bring a very unbiased opinion and very practical information for the listeners because I mean, frankly, these topics they can be really intimidating and there's so much information out there. So it's like when you're consuming it online, I mean, depending on the platform that you're on, you're going to be exposed to a vast degree of opinions. So I try to do my part to ensure that the listener is just getting the information that isn't largely anecdote, which I think within the fitness space sometimes is a pretty big bottleneck.
Corey, I'll tell you a secret. If you're on this podcast, you are also at it. I wouldn't ask that question if I didn't think so.
Well, I appreciate that. That's very, very kind of you.
But that's exactly why I wanted to talk to you today about this specific topic. So let's get straight into it with my first question being, what does the umbrella term performance enhancing drugs, or PEDs for friends, cover?
Gosh, so I kind of think about it like anything that's going to enhance your physique or performance. So growing up, I was tuned into the athletes within like Olympic sports, or even I guess you could say like recreational sports, who were, I would say the term PEDs was very much focused and oriented around them performing better. So them lifting more weights, being better at the sport themselves, running faster, just being more powerful. Whereas within the sport of bodybuilding, I mean, yes, like our bodies, our physiques are the vessel that is performing. So within the, I would say, scope of fitness, performance enhancing drugs or supplements, any kind of enhancement, it's largely going to be referring to what it can do to overall get you across that finish line related to improving your physique. Now, I know that it's one of those things a lot of people, they think with PEDs, okay, well, are these illegal substances? Are these ones that are from some sketchy lab that, are still research drugs? And it's not always the case. When I talk about physique enhancing drugs, performance enhancing drugs, really I'm talking about a multitude of supplements that some do require prescriptions, some are chemicals that are considered, yes, research chemicals, and others can be found over the counter and accessed pretty easily. So I know the terminology, it can be a little confusing because it's like, well, I assume that these supplements are ones that I have to go to a doctor to get a prescription for. But frankly, in the day and age that we live in, a lot of these can be accessed readily pretty easily.
That's a really exhaustive answer. Thank you. I'm wondering if you could also name some specific classes, and that's how I typically refer to them. And what I'm referring to is fat burners as opposed to anabolics. So essentially, the different types of compounds that one may come across and what exactly they do, and maybe some names as well, so that if somebody comes across them, or if somebody in the gym offers them, hey, would you like to try X? They more readily can understand what is being talked about exactly.
No, no, I love that. And this is essentially how I go about breaking down the fundamentals of PEDs as a whole. Is really there are two classes, like overarching classes I would categorize them as. You've got your anabolic androgenic steroids and then your non-anabolic androgenic steroids. So when we categorize the anabolic androgenic steroids, also you'll see if you follow my page, then you see like it's typically coined as AAS. These are the ones that are going to act on the androgen receptor. Now, these are ones that we do have to respect. They can cause unwanted effects. And more specifically, when we get into the different branches of anabolics, you have ones that are actual synthetic derivatives of testosterone, whereas you have just testosterone, which is commonly associated with providing really more of like a baseline, and I would say like can be used in a less ancillary way. So I guess let me explain that a little bit better. When you look at like testosterone, that's the compound that we're using for something like HRT or TRT, testosterone replacement therapy. Whereas when you're looking at something like Anavar, Primabol, and Masteron, these names of anabolic steroids, that they're DHT derivatives of testosterone. So they've been modified in a lab. And even though they still have very similar effects at the androgen receptor, they do act differently. And even though, yes, some have been approved for muscle wasting, cachexia, in more of a clinical setting, they're not ones that are being used for those reasons relative in the context to the sport of bodybuilding or in fitness, really. So that's one category. Is you have ones that I would say generally most people aren't going to need. And I think, like, really when we get into, like, need versus want, there's not, I mean, like, personally, I don't have a place to judge and determine, should someone, actually go through and use said drug. It's like, you're an adult, you have the right to put this in place. But really, I would like to put a lot of emphasis, especially in the content that I put out, in providing the user with enough information so that they are at least informed when they're using something that comes with a higher risk, like anabolics. So that's one segment. The other type of classes, the non-AAS, these are going to be ones that don't act on the androgen receptor. So you've got examples like growth hormone, clenbuterol, L-carnitine, which is one that like we kind of put into that category of non-anabolic androgenic steroid because yes, it's technically something that can enhance your ability to improve your physique, but it also can be bought over the counter. So I mean, that's where I think within this branch of non-anabolics, it's like we have to also respect the fact that not all of these are created equally. Clenbuterol is a fat burner. It's one that I would say, even though it's been approved, and I guess not clen specifically, but albuterol has been approved in the case of like asthma patients. This is still one that would require a diagnosis and a treatment protocol with it in place for users to access it, unless they were going to go UGL. Whereas growth hormone, which was the first one that I mentioned, that's one that even even with an individual who does have like physique related goals or even like anti-aging goals, it's going to be difficult to get a provider to write for this. So you're probably not going to have the same accessibility as something like L-carnitine, yohimbine, even clenbuterol in that case.
That was a really clear explanation. Thank you. Actually, I was going to ask you about the differences between TRT, so testosterone replacement therapy, and DHT derivatives that you've mentioned. And it sounds like you said they have very similar effects to testosterone, but they are synthetic. So already that clues me in on the fact that the testosterone using TRT then is more bioidentical. So it's the same as the testosterone that men and women produce in certain quantities. Would that be correct? Are there other differences as well? What kind of effects do these AAS drugs have that testosterone does not have?
Right. So when we're looking at testosterone, and I would say the way I want to approach answering this is rather like TRT is going to encompass just testosterone as opposed to you. I guess a better example would say you wouldn't use Anavar to support natural test levels. So your body is going to take that DHT derivative and it's going to read that like at a hypothalamic level as okay, well, we're covered. We don't need to produce testosterone. So not only is there a degree of difference in how they're going to interact at the androgen receptor, but you also have the fact that AAS, when used, I guess really the DHT derivatives or 19 Nors, which is another class that I would say we probably don't need to get into on as deep of a level as DHT derivatives, but you wouldn't necessarily put this in place unless you are trying to expedite that process of enhancing your physique or enhancing performance only because of the fact, and I guess I should say that with a caveat, you wouldn't put them in place without testosterone as a base on account of the suppressive effects that they're going to have at the HPG or HPO axis.
I see. So let me see if I understood this correctly. If you want to use these DHT derivatives, you want testosterone as a base. Whereas if you are going to take testosterone as part of TRT, you wouldn't need bases. The testosterone that you're taking as TRT is the base. Is that right?
Exactly. Yeah. So the starting point, regardless really of goal, is I'm going to say testosterone is going to serve as that base. And regardless of gender, regardless of, I guess, athletic potential, I'm always going to recommend someone starts with TRT as a base for just from an efficiency standpoint, because it doesn't make a lot of sense if you're running, let's say, and the duration that you would run, let's say an anabolic, is going to vary dependent on your goal and your biological gender. So, in the case where you're prioritizing minimizing the risk of virilization, which is an accepted effect of all anabolics, testosterone included, if your goal is to not develop any masculinization, so any androgenic effects, then you would want to be really cognizant of the use of those AAS, those ancillary ones, and as well as testosterone. Just does it actually make sense? And do you have the runway to really tolerate the potential androgenic effects?
Excellent. And that's actually a good segue for me to ask you the following question that I have, which is what are the short and long term consequences of PED use? And I think I'm assuming, you might correct me if I'm wrong, but you may want to speak about both the classes that we've just discussed, because I imagine they might have slightly different effects and
Mhm.
consequences.
Totally, totally. So when we look, and this is really where we have to consider the short and long term effects and the potential risk, that those are going to be specific to the individual. So to the individual's goals, and more specifically, what they don't want to happen. So a lot of the content that I put out is geared more towards the female athlete who is not looking to incur androgenic effects. So, this, for example, is deepening of the voice. Obviously, you're going to see suppression of gonadotropin, so anovulation. You could see clitoral megaly, you could see hirsutism, you could see alopecia, acne, oily skin, overall a decrease in skin elasticity. Now, these are all aspects that I think really need to be defined by the individual user, because I can say, like, my definition of what's feminine to me, what's important in terms of femininity, that could vary greatly from another athlete who's within the same category, who's of the same age. So I think as a coach, and I think really as a user, and I encourage clients and listeners to do this, is if you're going to be using either testosterone or ancillary anabolics, so Anavar or something of the sort, have a very clear idea of whether or not you're willing to accept androgenic potentiation, because not all of these anabolics are created equal. And the interesting thing is, we do have, thanks to the trans community, we have studies that do depict really the threshold in which those androgenic effects are more likely to occur. Which, I mean, like, as far as literature goes, it's incredible to see that those studies are very well designed and actually are on humans. So when we look at testosterone for, let's say, the risk averse female, which is really just a term I use for females who are looking to have something in place, whether that be TRT or, let's say, an anabolic like Anavar. If someone is risk averse, I mean, my understanding of that is that they don't want to expose themselves to masculinization, meaning that for testosterone, we really want to keep them under the threshold of 100 nanograms per deciliter, because past that point, we do have literature that supports that those changes can begin to occur. And in the case of TRT, this is something that if you have in indefinitely, which, I mean, yes, you could say it's not a lifelong drug, but while you have it in place, it is going to cause the suppression of endogenous production, so your natural production of testosterone. So this is important because if someone is, let's say, going to introduce testosterone in a TRT fashion for a brief period of time, we need to understand that while we can assume that their natural levels will be recovered post cycle, which, just I'll interject here, we're not really going to cycle testosterone. Again, it's more serving as like basal coverage. If we were to discontinue, there could be a little bit of a lag in that re-up of your HPO or HPG access, which I think is really important relative to the individual's biologic age, because at that point, we can assume later in life, someone's not going to see that same restoration of those natural levels. So I'll pause here because I know that was way too much information in one go. I definitely want to get into the non-androgenics, but do you feel like I covered everything that you were asking within the TRT scope?
Yes, I believe so. And I think you've also done a great job of covering the potential risk of virilization, risk using that as a term for people who do not want to virilize specifically, and the risk and the all of the you've described also what virilization could actually include, which was great. I'm wondering in terms of other effects to I'm thinking about for example heart and other organs. I'm wondering if those are effects of the other compounds then that you might want to cover next.
Yes, yeah, and I think that's a great segue, and really, I would say my line of work, because I'm largely serving a demographic who is risk averse, or who isn't necessarily going to be on PEDs, anabolic specifically, for a long period of time. It's an area that I am not like other bodybuilding coaches where I work with men who are going to essentially be on these compounds at what we can clearly define are abusive dosages due to the sport and their needs here. So within really the general framework of what is the overall systemic impact of AAS exposure, so TRT as well as DHT derivative exposure. Yeah, I mean, like we can definitely draw a correlation with extensive levels leading to potential cardiovascular impacts. So I like to think of the cardiovascular impacts really as something that we need to be very clear on. Is it an issue with blood viscosity? Do we see an increase in red blood cell count? Do we see a skewing of LDL? So do we see the valves essentially that the heart is working to pump blood through becoming more and more calcified over time on account of a high degree of lipid exposure? So in that case, I guess really when I look at the cardiovascular system, I almost think about it like plumbing. That's the analogy I typically use. Is the issue viscosity, so the actual sludge that's going through it? Is it narrowing of the vessels themselves on account of calcification, or potentially just using a drug that's now creating a very strong pump that over time will likely run into malfunctions or just decreased functionality. So, within cardiovascular health as a whole and the impacts of anabolics, I would say there is a potential risk, but this is largely going to be tied to your overall degree of exposure. And I think, regardless of whether we're talking about individuals who are looking to just support overall fitness and generally feel better about their body, or in the case of someone looking to correct their hormone levels to establish normal to normal high levels, but not super physiological levels, we still have to look at their comorbidities that they're bringing to the table. So, past the cardiovascular system, because essentially we can say that, and we know this because of literature, that all anabolics, like a higher degree of exposure at higher doses, can have all cause mortality. So it can impact all of your systems, really. So your liver, your renal system, hematology, cardiovascular, as well as your endocrine system. So, having a very clear understanding of like, how is someone coming to us? Are they coming to us with some kind of indication that their liver is already disadvantaged? Do they already have poor kidney perfusion? Are they already at risk, whether from a genetic component or a modifiable lifestyle factor related to their cardiovascular system? So generally, it's not something that I necessarily run into a lot, because the enhanced users that I work with, I mean, a lot of them are just taking TRT, and the ones that are using ancillary anabolics on top of that, it's at very low doses for very short durations.
Understood. So to vastly simplify everything you've explained so clearly, it sounds like the poison is in the dose when it comes to these compounds. And also, we want to take into account the individual's starting point from a health perspective to establish the potential degree of risk, if that's right.
Perfectly said, and much more clear and concise. Yes.
Thank you. I appreciate that. You know, it's so interesting because I don't use performance enhancing drugs. I'm only on TRT as part of my medical transition from female to male. And yet I am so familiar with the vocabulary that you use and everything that you talk about, because that's what I go through to look after my health while being on TRT. So I find it really fascinating.
It's very interesting because I do think, as I've been discussing this topic more publicly, I've tried to be mindful that I'm being inclusive, and I'm also being fair that not everyone's definition of masculinization or femininity is the same. And I think that's something within the space of performance enhancement education that we really need to have a strong foothold in, ensuring, it's not my place to tell another girl that, hey, your voice, that is getting too deep for her. That might actually not encompass masculinization. And if that is a concern for me, well, then the protocol may be a little different. So that's where I am trying to do my best to be very clear and accurate because, too, I do think even on the biological male side of things, there are aspects to virilization that they themselves are not looking to incur, such as hair loss, which recently I just did a podcast with someone who very low test to begin with, biological male, and he actually voiced this, and I love that he was like, I went through my own series of virilization once starting TRT as well as ancillary anabolics. He heard his voice drop. He started to see hair thinning, and it wasn't until he was under the right guidance and really was able to align like what are his goals and what are the degrees of androgenicity he was willing to encompass, that he finally got like the right dose and the right protocol for him.
Ah, that's so interesting. Yeah, I'm going through a similar experience in that when I started taking testosterone, it was in the form of gel. But then, for various reasons, my levels were always just below the correct range. So I was getting virilization, but also it could have been better. And for my own peace of mind, so to speak, I would rather be within the physiological male range. So speaking about that to my doctor, we decided to change the way I get testosterone administered. So now in 2023, I switched to injections. And ever since, I've had the opposite problem where my body is very sensitive to the injection. And so the type of injection I take is a compound called libido or testosterone decanoate. I cannot even not even going to attempt to pronounce that. It's too difficult. But basically, I originally, the typical interval between injections is 12 weeks. Currently, I'm experimenting with 18 because anything less than that has made my levels shoot up, and personally that's not where I want to be. I don't want to have my testosterone levels to be above the physiological male range, so I'm still trying to fix that with the help of my primary care physician.
Gosh, that I find that so fascinating too, because I do think like the components of what not only feels best, but then how this translates to labs is an area that I think is highly misunderstood for really regardless of the goal. And this is something within like the scope of TRT specifically in different forms of administration. I mean, it's extremely rare for me to work with a client who is actually offered injectable testosterone as their starting point for TRT. And I can speak to both the female side who is looking to support normal to normal high levels, but either they're put in a position where they're only offered a gel form, or alternatively they're offered a pellet, which I mean, like frankly, I think is a little more morally questionable only because it is a way that a lot of private facilities will tend to drive up profit. But typically, what I see is with individuals who've been put on pellets who are biological females looking to maintain that, their levels are very, very far past what we would even say is normal high. I mean, like many of them are coming back in the 400, 500, 600 nanogram per deciliter range. And thank God they haven't virilized, as that's something they don't want to incur. But I imagine on the male side of things and I guess really with that being the finish line, finding that spot for you that is appropriate for the speed in which you want to see those changes. I imagine that has to be frustrating or just a little confusing depending on who you're working with.
I think I know for other people it's different. Some people, understandably, have taken a long time to realize that they were gender diverse, so they really want to see changes quickly. I've always been patient. Like, as soon as I had the opportunity to receive TRT, I was so grateful. And I just decided I'm going to sit back, relax, and enjoy the ride because this is where my life as my authentic self begins. I'm not going to ruin it by trying to be impatient. So personally, I wasn't frustrated at the speed of results of lack thereof. When my levels were inadequate, I was only worried that I might not get. It's hard to put into words, but essentially to me, testosterone is becoming who I am. It was to me, it's like I was born hypogonadal, and therefore I need TRT to have functioning sex hormone levels that I wouldn't otherwise produce myself. So I was only worried that I wouldn't be able to almost grow into an adult properly if my levels were never, like I couldn't realize my potential as an adult if my levels hadn't been in the right place. But then on the opposite end of the spectrum, when they go up too high, they also seem to drive up my cholesterol and my blood cell count to a degree that I don't want to have because of the long-term effects compounding over time. So for me, it's more about finding a sweet spot where I'm very happy with the outer effects, the viralization effects that I've had so far. I really feel like myself, I don't really need anything more than what I already have. I aim to maintain where I am. It's more I'm thinking about the fact that I'll never be able to stop taking testosterone. So I want to make sure that I can take it and prolong my health span as long as possible.
I love that. Thank you for sharing that insight, because this is all new information for me, and I can definitely appreciate how being able to make that commitment lifelong, that part isn't necessarily then that isn't a considered like a hard question for you to decide because you are um, living in a manner that now feels like true to you. But I think it's amazing that you're also considering that, like, okay, well, this can't be a free ride. There's got to be something here that is going to catch up to me. And I think that's where having a very clear idea of when you're getting labs done relative to your last injection, to me, that's one of the biggest mistakes that I see with the population I work with is that typically providers are encouraging individuals to check trough levels, meaning the lowest dip before their injection, which I think, again, like my population is risk averse. So I'm like, we need to make sure that the peak, like the highest point we're getting to, is not superseding and going into that super physiological territory. So I think for listeners, I think that's a really important takeaway is that if you're using any form of testosterone, and I would say like with a gel, with a patch, I don't think it's going to be nearly as consistent and stable just because of the pharmacokinetics associated with that form of administration. Your body, I mean, I know for me, like if I'm on thyroid hormone, if I'm taking that for a contest prep, or if I'm at my peak off season weight, my metabolism is going to operate differently than if I'm at my leanest, 20 pounds lighter. So we have to consider that relative to alternative forms of TRT because truly, if we're working within a narrow therapeutic index, which I would even say it sounds like what you're describing that you are as well, because there is a point where it's no longer favorable and there are consequences. So, making sure that you're capturing that at the appropriate time, I think, is really important. So, I typically recommend 24 hours after your last injection, and also knowing that the more frequent injections that you have per week, more stability in those levels. And I myself have been on TRT for almost 3 years now. I found that daily injections provides the most consistent results and the most, I would say, subjective, qualitative effects that I'm really seeking specific to libido and energy levels. So within that, the one problem that I think a lot of individuals struggle with is being able to access a dose that is appropriate and that's concentrated in a way that in the case that they are starting at lower doses for their weekly milligram sum, that they're able to still do those daily injections just on account of this is something that's completely new territory for most providers.
Very, very interesting. Thank you for going into that. And since we're on the topic of different forms of administration, are there different risks to consider when we're taking these drugs in different forms? So injections as opposed to oral tablets, for example. Because for example, once upon a time, I heard somebody state that it was better to take an oral tablet because essentially they weren't comfortable with needles and they thought that it would be healthier for them. They thought, they thought actually that they wouldn't get all of the negative side effects that you would get with injections because they were taking a tablet. And I was like, that's going through your liver. I don't know how that could be better, but maybe you can enlighten me and the audience on that.
No, that's such a good question. And I'll say one of the reasons that I favor injectables is for the specificity then in the serum level. So I find that to be of top priority in healthy individuals. But you're absolutely right that when we're looking at anything that is absorbed orally, your liver does have to metabolize it. And I don't think, I challenge anyone, please correct me if I'm wrong, but I don't think that there's a high degree of liver toxicity or the impact necessarily is going to be as great as, let's say, Anavar. Anavar is an oral anabolic. So when we're comparing those, and I think that's a pretty fair comparison, is if we're putting them side by side, and then it's like, I can say for my dose, like I'm taking 0.5 milligram a day of testosterone. So comparatively, the starting dose for Anavar, an oral anabolic, if I were to take that, I mean, like we're looking at 5 milligrams a day, and I would really prefer 2.5 milligrams a day to start. But I know for a lot of people, they're going to start at 5 or even 7.5 or 10. So when we compare the doses just in this regard, and I guess I should specify that I'm using 3.5 milligrams for the starting dose for female TRT who are risk averse. So in that aspect, it's like, we're looking at a dose that's 10 times as high. I mean, like it's pretty significant. So the degree of hepatic toxicity, so the impact on the liver is going to be much greater with um, an oral anabolic, even as opposed to an oral testosterone. But past that, let me see. So when we're thinking about the potential systemic impacts, I believe it's either the gel or the patch of testosterone. I'm leaning towards the patch, can have an effect on free test or DHT. Um, I'm maybe misremembering this. It's honestly not one that I have a lot of clients explore, so I can't really speak to the fact like, oh, I see this all the time. But people much smarter than me have noted that there can be varying degrees of modulation, essentially, of these other circulating androgens. And for listeners who aren't familiar, when we look at SHBG versus free test, you can have, let's say, adequate levels of total testosterone, but if that SHBG is elevated and that free test is low, that's essentially going to limit your capacity to tap into that total amount of testosterone within your system. So this is also something that we need to consider based on the individual's needs and desires, is to the degree at which their free test is elevated, how should we consider elevating their total testosterone? Because for some women, even naturally, they find that they don't have a lot of runway, which is really more like a colloquial term that I refer to when I'm talking about your amount of exposure you can tolerate before you begin to experience unwanted effects. So within that realm, I think it's important to have a very clear idea of what your tolerance is. If, let's say, you're someone who naturally has struggled with darker facial hair, acne and oily skin, I mean, I see this one to be really detrimental to the individual who's struggled with this their entire life, maybe even has had acne scarring, even if they're technically within the physiological normal ranges. Either Either way, it's like the free test being so high and maybe even their DHT being on the higher side as well, that can make it to where those unwanted effects, well, say androgenic effects, are a little too burdensome. So that's where I think a good way to like round this out is like testosterone as well as all anabolics have an anabolic potential, which is just the hypertrophy potential, the potential to accrue new tissue, as well as that androgenic potential. So it's really like we can't accept the anabolism without the androgenicity. And that's where I do try to caution users, if they're not okay with the androgenicity, then we need to respect the fact that we need to probably be on the more conservative end of the spectrum in terms of dosing and total lifetime exposure.
So what you're trying to find, if somebody is um, not willing to undergo a certain degree of virilization or any virilization at all, is the sweet spot where they are still getting to enhance their physique, which is their goal, but also without incurring the side effects of virilization, because you can't have one without the other, is what I'm understanding you're saying.
Yes, yes, that was so perfectly eloquated. Thank you.
Not a problem at all. I think being a podcast host, I just learned to give people the cliff notes at the end of a conversation.
But no, that was perfect. Yes.
So then my next question would be, you've touched on finding the correct dosage for relative to your tolerance. You've also touched on well-being. And I'm wondering, in terms of your day-to-day life, what kind of effects could you expect in terms of libido, um, hunger levels, mood, or anything else that I might be missing with this question?
I love that. So, what we're describing, I guess what we'll go into now is more of those subjective metrics that they are vastly important. And frankly, if we're putting TRT in place, it's likely that we're doing so with the goal to correct some kind of symptom or some complaint of the user. So, in the case where I'll just share like when I started TRT, I was 26, which arguably that's a little young, but where I was at was my libido was very erratic. Even outside of bodybuilding, I wasn't seeing that rise. I was seeing a lot of suppression in my circulating androgens. And really, with the goals that I have within the sport of bodybuilding, I kind of made the decision. I'm like, it doesn't make a lot of sense to expose myself to these environmental stressors, even a self created environment, with low testosterone already, knowing that it's probably only going to go back down. And how that manifested for me was very much lower libido, low energy, discrepancies in sleep patterns. Big one was hunger signaling and satiety, which I will say, like within a few weeks, like 4 or 5 weeks, I began to see leptin normalize. At least that was what I experienced. So um, biggest improvement that I've seen that I think a lot of individuals, a lot of my clients note are the consistencies in libido, as well as energy. And I mean, I'm very honest, like last year, I was in nursing school full time, working full time. You're going to have days where it's just not there, and that's okay. Even with TRT like that, it's not perfect. And frankly, you don't want it to be too intense or to an extent that is uncomfortable, which I know for a lot of individuals, a lot of males that I work with who are on super physiological doses of testosterone. I mean, they're, just past the 1,000 nanogram per deciliter mark. Many of them who are, going through it for the first time, they're like, I don't really enjoy this. Like, I like the improvements in libido, but not to the extent that now this dose is providing. I think I'm actually more comfortable scaling it back down. Another big one is the energy and the recovery capacity. So, again, this is one when you're busy and you're doing a lot, like, and you have life stressors, you're you have the propensity to experience fatigue and lethargy. So, it's not something, and unfortunately, I have clients that are like, well, I think I might feel better at a higher dose, even though they're right at the cusp of 100 nanograms per deciliter. And I'm like, sometimes you're just gonna have days where you get your ass kicked and like you're exhausted. And I wish it could solve all the problems, but it's not going to. So I think having again very realistic expectations in terms of both libido and energy, which is another point I want to circle back to, is with performance anxiety and ED. That's another area that I think a lot of males assume that correcting testosterone levels and putting them back to normal high range will absolve all potential issues with erectile dysfunction. And that's something that I do think is largely psychological. I mean, like when we look at the domains of hypoactive sexual disorder, there are three large components that go into it, but we see perfusion. So we need to make sure that the organs are actually getting perfused correctly at the appropriate times. But we also see the ability, I guess, really the impact psychologically. And then I'm sure listeners can relate to this. That can be very compounding. And I guess I should preface this. I shouldn't say that that's very exclusively specific to men, because I do think that women can experience performance anxiety too. And that can then be coined in their mind as like, okay, this is an issue. And potentially then every time after that, it just gets worse and worse. So I would try to explore, are there any modifiable factors in addition to supporting your hormones and keeping you within normal range that could help facilitate more stability there? But I guess when I talk about libido, I want to be super clear, like, oh, there's so many factors that go into this.
Yeah, that makes a lot of sense. So I'm wondering now about the specifics of the bodybuilding lifestyle, so to speak. So, training and nutrition differences when we're training and eating as a natural person versus training or eating when we are enhanced. And you can start by talking about training and then move on to nutrition after we have an exchange. We don't have to cover both at once because that might be a really long conversation.
No, no, I like chunking it up like that. So within the confines of being enhanced, you're going to have the ability to train harder, train more, and recover faster. Where you see a lot of enhanced athletes run into issues is that their avascular tissue, so their tendons, their ligaments, they can't necessarily keep up with the stress and the strain that they themselves are putting their muscles under. Now, I do think this is something that is typically a cop out. You'll see a lot of bodybuilders, note that because I'm on enhancements, I'm going to perform these very interesting types of training modalities, these like just extremely high volume, which I don't think is necessarily the correct, and then being enhanced as like, okay, well, I have to train this way. I can't train under heavy load, or I can't do back squats or perform movements that don't have a high degree of external bracing. I think a lot of this comes from ignorance. I think there is a lack of understanding within the fitness community as a whole around biomechanics and functional anatomy. And that's something that I think if you, like when I say like have good technique, I mean like you can maintain the correct positioning, like from your scapula to your pelvis, and you obviously have adequate hip function. If you're able to do these things, then you can expose yourself, whether you're natural or enhanced, to very impressive degrees of load. But this all needs to be balanced out with your recovery capacity. So, for both the natural and enhanced athlete, and I would say just for listeners, the enhanced athlete is going to have a little bit more they can get away with. They're going to recover better. So for the natural athlete, they're going to have to be very cognizant of what their fatigue management practice looks like. And I mean, like typically in the conversation around recovery, what gets lost and kind of falls on deaf ears is the fact that your sleep and your diet, those are the two biggest contributors to managing fatigue. And if those are maximized, if those are, being monitored, and you are making sure that they are just as much a priority on the diet side, more the micronutrient standpoint, and more specifically the quality of food. But if you're managing those, that's going to have the biggest impact related to your training. Whereas I think a lot of people hope that they can just get a massage gun, or go do a cold plunge, or have a chiropractor, acupuncturist work on them. And it like kills me because I'm like, you're putting so much money into something that like you have the ability to modulate completely for free. Well, I guess with diet, not for free, but it is within your control.
Lastly, if you want to support the podcast and help me reach more people, please leave a 5-star rating or review on any podcast platform that you're using. Thank you very much for listening, and I'll speak to you soon.